One, ready when you are, Tammy.
Good morning. My name is Tammy Walden. I am a Special Projects Coordinator with the Department of Behavioral Health Services. In recognition of May Mental Health Month, the department is hosting a weekly web-based opportunity to meet community providers utilizing the Behavioral Health Initiative to create a safety net of behavioral health supports in our community. Today, we are joined by organization leaders providing crisis supports, which improve the response time for individuals in a behavioral health crisis and help to support linkages to appropriate stabilization and recovery services while minimizing involvement of the criminal justice system. The goal with this series of webinars is to give the community an opportunity to learn about the great work being done in the community and how supports from the BHI are assisting that effort. Please join me in welcoming our first presenter, Sergeant Charles Crook, with the Albuquerque Police Department Crisis Intervention Unit. Sergeant Crook is here to provide a brief overview of the Mobile Crisis Team program, which is a collaborative effort between the City of Albuquerque and Bernalillo County to respond to emergent mental health related crises in the community through 911 dispatch throughout Bernalillo County. The MCT provides an on-site mental health assessment and crisis intervention to individuals in acute crisis stemming from a mental health related issue. So good morning, Sergeant Crook. I'm going to go ahead and begin the PowerPoint presentation. Thank you for being here.
And thank you for that introduction as well. Like she said, I'm Sergeant Charles Crook with the Albuquerque Police Department in the Crisis Intervention Unit. Currently, I'm overseeing our mobile crisis teams and our training coordinators, which provide training to the entire department. Okay, and to explain what this first slide is talking about, it is including the mission that was just described too, because it's all about connecting people living with mental illness to these services as well. And we're doing that using law enforcement, which I know is a very touchy subject right now too, and how we're going to do it. And that's where the MCT really comes in as a great resource for us as a department. Oh, we went away from the slide, but
Sorry about that. Go ahead.
No, it's no problem. And so with the Crisis Intervention Unit over at Albuquerque Police Department, there's a couple different branches of it, and the mobile crisis team is included in those branches. So not only are we providing training, but we also have another section of detectives that will go on home visits for follow-up investigations. This is one great benefit to having these mobile crisis teams, because they're in direct contact with those detectives who can come out and do a follow-up. Because if you've seen traditional like law enforcement, there's a uniformed field officer, and then there's plainclothes detectives. So the home visit side are these plainclothes detectives, while the mobile crisis teams are great because they have a clinician and they have an actual marked and uniformed police officer with them to provide security. But the actual emphasis is keeping people inside the community and avoiding pursuing charges or anything that would put somebody into the justice system. It's actually to keep them out. That's the mission, so that we can use the medical treatment or we can get them the services that we've talked about before. The other portion at the bottom of this slide is our COAST unit. And what that stands for is the Crisis Outreach and Support Team. That's just yet again another resource that we can use through these mobile crisis teams when they come across a situation that does not require a uniformed officer. So these are lower level where there's not as much of a degree of a threat to others, where we can send just a civilian for a follow-up at a later time. Before I move forward does anybody have questions about any of those? Okay, if no questions, then I could move on to the next slide. Okay, as discussed, mental health crisis is really our focus in this part of the department. Included in that are people who can have those acute crises, but it also includes people with behavioral health components as well. And so you could have an individual that's in crisis. You could also have somebody who has a developmental delay or other behavioral health components as well. And as I mentioned before on that previous slide, this is geared towards the treatment versus the criminal justice system. Now, the reason I have that point up there is because on occasion, there are degrees when it can come out as something behavioral health related, but we find out that it's actually something that does need to be addressed through the criminal justice system. If it was something that there actually wasn't a behavioral health component, we're equipped with these mobile crisis teams to handle that situation. And that's what makes them really unique as like a hybrid response. So, for example, we get dispatched to a call that's supposed to have behavioral health. They find out it's not, and it's purely a criminal situation. We have a uniformed officer there that can handle that situation or request the appropriate resources. The entire thing for the last point on this slide, all of this is generated out of our CASA compliance. What that stands for is the court-approved settlement agreement that Albuquerque Police is involved in right now with the Department of Justice. Part of that had to do with the Fourth Amendment violations in the past and use of force between Albuquerque Police and the public. And so among those stipulations, there's a large portion of these paragraphs with the settlement agreement that have to do with mental health and making sure that Albuquerque Police Department is using everything that it can to address these situations the right way and provide these resources. So like we've been mentioning, like in some instances, it's not going to be something where we're going to have a criminal element where we're trying to get somebody some help. And the CASA clearly outlines what we should be doing to avoid particular uses of force against people with mental health conditions as well, or when it's warranted, that everything is checked off the way that it should be while still abiding by everybody's rights. Does anybody have questions on any of those points before I move on? Okay, we can move on to the next. These are some statistics that I was able to pull from our 2019. Our 2020 data is incoming. We're still compiling that at the moment too, but we have some numbers here that should help an understanding of what our stats look like for now. Officers are all getting, during their academy, they get 60 hours of state mandated behavioral health training. And then after their training is completed, they do an additional 40 hours of crisis intervention training. This was also brought up in that settlement agreement we were talking about on the last slide. In addition to that, they continually take 2 hours of MOE training. And that's, I'll get you that acronym here in just a second. I had that noted as well. In all the years that I've been doing it, we always call it MOE and we don't look at the definition a lot. The next point is ECIT, and that acronym, what that stands for is Enhanced Crisis Intervention Team, or intervention training. And the reason that 40% is next to it is because, as mentioned above, every officer gets that training, but once they're done with their 40-hour crisis intervention training, they have the option, whenever we notice somebody who has skills with it, that they can take enhanced crisis intervention training. And you have to have that enhanced crisis intervention training to be on these mobile crisis teams that we're talking about whenever you ride with a clinician. The next is our MCT stats for how many certificates for evaluations they'll do in a week on average, between 5 and 10. Is everybody kind of familiar with what a certificate for evaluation is? Because if you have questions on that, that's whenever a doctor will write up a certificate for evaluation for an individual in mental health crisis to be picked up by police officers to be transported to the hospital. The next stats are some of these. It's showing that we had 8,515 contact sheets compared just in a couple of years compared to 3,000, showing that we've more than doubled in stats whenever it comes to responses to people with behavioral health components in police calls. And that's a big number. And so that's why these mobile crisis teams are a good response to that situation. 2,796 of those are voluntary transports where we can convince somebody to go on their own will. 1,832 are involuntary. When somebody's in that crisis and they are not wanting to go to the hospital, but we have to get them there so that they can get treated, that could go with what we mentioned above for those certificates for evaluations. We had 217 arrests, 125 disengagements, and 94 alternate enforcement actions. And the best number that I like to brag about is that 1% of all of those calls, of those 8,515 sheets that we're talking about, were where force was actually used. Anybody have questions on any of those statistics? Okay, if no questions, then we can move on to the next. These are some of the challenges that we're facing right now. We do have legal issues that arise because you have to consider when a crime has occurred, where somebody's at in their state of mind, and proving something like intent, that can actually become a unique situation. One example I could bring up recently is like if you have battery on a healthcare worker, where an officer is responding and determining if this person needs to be charged. You also have to assess how much they actually know of what they're doing in their state of crisis. And so that's just one example that you can have of legal issues that come up. Also, we have an additional state statute here in New Mexico of 43-1-10, and that's what gives officers the authority to be able to transport somebody against their will for mental health. And that's only when those officers have really good evidence that they could harm themselves or somebody else. And then that subject comes up in the response section of this slide, where we will meet with our legal teams and the hospitals to resolve these the best we can. Challenges our facilities as well, because we are currently bringing a lot of people to the hospitals, to the emergency rooms, and using the portions of the hospital for behavioral health related calls, and individuals on top of them already being pretty full whenever it comes to emergency departments. We have listed here on the response that we're trying to work on is using the care center more, which was formerly known as MATS also. And a crisis triage center is in development as well that we'd really like to see to help streamline to get these people into. And that would be perfect for a mobile crisis team to get somebody where they need to be in the hospital. Staffing is an ongoing challenge for the department. If we could get more officers, that would be great to be in the field. And I'm currently trying to expand this mobile crisis team because over the last 4 years, it's proven to be very effective in what they do. So I have 4 now. I'd like to get up to 8 if I could and double that number. Force, as I mentioned before, can always be a challenge whenever it comes to these. And so that's where we really have to provide the best training we can with the other facet that I have in the department. The last point that I made is the lack of resource. That kind of goes into what I just said about the crisis triage center, because what we currently have to do is take them to emergent care as listed on the response. So when an individual needs to be transported to the hospital, we're taking them to the emergency room if they're not a specific behavioral health hospital like UNM PES located at Marble. Anybody have questions on any of those challenges or responses? If not, I can move on to the next. Okay, our partners in collaboration, we have an memorandum of understanding, an MOU with UNM currently. We're hoping to expand that to more hospitals too, because that's data sharing between the department and the hospital that can be really important for us, especially with ongoing investigations or repeat consumers that we transport. Next is we partner with, as mentioned before, Bernalillo County Sheriff's Office and other law enforcement agencies. Our judicial systems, when we can use, when we're going to be taking a mental health route or a treatment route, then being in contact with them so that we all have an understanding is also beneficial. ACS, which is Albuquerque Community Safety for a civilian response. That's something on the horizons that we're really going to play a role in helping with the training and development of getting a pure civilian response to certain non-threatening like behavioral health calls, so we can get some law enforcement out of that response altogether. The next MRAC, which is the Mental Health Recovery Response Advisory Committee. I have recover on there, but it's response. But they dictate, we meet with them on a monthly basis, and they play a big role in getting input on department-wide training and our mobile crisis teams. And also at the end, Bernalillo County Behavioral Health Services is also a partner, as we've mentioned, with our MCT and their MCT as well. Anybody have questions on our partners in collaboration? And I apologize if I'm going over time also. All right, then if no questions, then we could move on to the next.
All right, thank you, Sergeant Crook. That was very informative and helpful. Next, I would like to introduce Dr. Marcia Harris, who's the Assistant Director for Bernalillo County Department of Behavioral Health Services and oversees direct care services on the CARE campus. Dr. Harris is here to speak with us about the Crisis Stabilization Unit, which supports individuals experiencing a mental health crisis, and how the program is working to fill the gaps in the crisis behavioral health continuum. Dr. Harris, welcome.
Good morning, everyone. Good to be with you this morning. Let me give a little background information about crisis stabilization versus crisis triage. About a year and a half ago, the state provided licenses for both crisis triage, which is about a 24-hour overnight service, and crisis stabilization that can be up to 14 days. And we have in Albuquerque, in terms of some of the crisis triage, of course, UNM psych emergency, but the other hospitals also have consult liaison departments who do evaluate people in the emergency room when there might be psychiatric or behavioral health issues. The gap comes, I think, in two different places. One area is people who are seen in an emergency setting who would not benefit from inpatient psychiatric care, but really will be more continuing at risk if they just return to the environment they were in. So that's one group that is really appropriate for crisis stabilization. Another group that we see are people who actually have an inpatient hospitalization, but if they're only released from the hospital, they have no community supports. That's often going to be discharged maybe to a shelter or sort of a high-risk place, which puts them at sort of a risk of a return to challenges to their functioning. So we also see referrals of people who have had an inpatient psychiatric episode, and they come direct to us after release. We do serve only adults right now on our campus, so they have to be at least 18 years of age. In the year and a half of operations, we've seen people ranging in age from 18 and 1 day to age 80. with a variety of issues. We are also a voluntary program. So if somebody comes and says, gee, I don't think I want to be here after a day or two, they do have the ability to leave. And our data show that between a quarter to a third of people indeed make that choice. And often if we encourage them to help us, let us help them connect with some safety. If we have concerns about safety, we do call for welfare checks. Given that we're a 14-day program, a person has to be able to participate in some of the unit activities. In the 23-hour, the admission criteria are much wider. It's almost like a psychiatric emergency room. And in some smaller communities, this is definitely a need. So I think we can move to the next slide, Tammy. So we're a social model program, and people say, well, what does that mean that you're a social model program? What it means is that our focus is on that individual as part of a community. In terms of having a significant mental health disorder, there's often an alienation from the community, not a lot of supports. So we really see our goal as addressing the disconnections in the lives of individuals, primarily with co-occurring disorders. The crisis unit in 14 days doesn't do therapy, but it really begins to address the disconnection from self. People come in, they've been through crisis, their sleep is incredibly disruptive. They may have, well, in fact, about half of the people we see are homeless, and they're finding it more and more difficult and challenging to survive on the streets. So often they become suicidal in the context of homelessness, and all the focus has just been on moment-to-moment survival. So we try to give them an environment where there's time to sort of reconnect as a first step with themselves. We do have a client-centered program. We have several groups and individual interventions. People are not required to attend, but they are encouraged, and you can see some of the work that's come out of our art experience group in the background of the slide. We have a variety of both verbal and expressive interventions, the art therapy, meditation, both walking meditation and the more traditional meditations, some real encouragement for people to become physically active on our campus, which is large. And really, I think one of the most important parts is very intensive case management. In 14 days, we are looking to help somebody get to the next level of safe and appropriate housing and treatment. We can go to the next one. There are some limitations to the social model. We can't start somebody on medication. We can't adjust somebody's medication if they're having difficulties. We do have the ability to assist people in taking medications that are prescribed to them. So one of the situations that often happens is the person is seen in an emergency or a consult liaison situation. They are started on a prescription medicine. They come to us with the medication, and we assist them in taking the medication. At this point, our pharmacy license does not allow us to even provide over-the-counter medications for fairly routine things. We cannot just give ibuprofen for a headache, for example, or something for indigestion or allergies. We do have access to emergency nursing assessment 24/7. So if we believe that somebody medically is experiencing something that needs to be evaluated, we have the ability to have an on-site RN evaluate whether that person needs to be transported to urgent care or even emergency care. We are working with our medical unit, which is actually staffed by University of New Mexico Hospital. to be able to provide medications for some of those minor medical issues. When I call them minor, that means you don't necessarily need to see the doctor, and you're not going to become seriously ill. But if you have a serious headache, it's not minor to you. So we are looking forward to that, the ability to respond a little more to some of the ongoing physical issues. We see people with chronic medical conditions, but again, that those have to be stabilized. People need to be able to bring their medications so that, for example, someone with diabetes, somebody with asthma needs to be able to bring their medications with them. And again, we can assist in taking those medications. What we find is that the clients generally respond well to the activities and interventions. People with who have carried a diagnosis of significant mental illness sometimes are not seen as a whole person. They're seen more as their illness. And one of the activities we've had that has really allowed a client to see them as much more than the challenges they face, or other people to see them that way, is a journaling activity. And it's been really great to see people step back, have that time to really think about themselves and express themselves. And also, clients are often a support to each other. Sometimes clients might have some conflict, but more often in this small, fairly quiet environment, they do support each other. And we've seen ways in which people come together around music or art and come away with a very positive experience. The other thing with a 14-day program is we have time to find a viable follow-up treatment program and to really make a direct handoff to another program. So for example, almost half of the people we see, in addition to having a significant behavioral health diagnosis, are also challenged by substance abuse. So we have 14 days to find programs that can help somebody with co-occurring disorders. And often that might be in Albuquerque, but sometimes it's up in Santa Fe, even programs in the south of New Mexico. We've had some young people with significant developmental disabilities who were on the DD wait list, who somehow fell through the cracks, and we've been able to find placements for them, so that long-term placements, so that they can be safe in the community. So those are some of the strengths that we feel our program brings. We do have, like I said, widely varying lengths of stay. Our average length of stay is almost 8 days. So nearly half of our population stays over 8 days and gives us time to help find that viable placement. But we also see a third that really quickly come in and quickly leave. We have to do some evaluating as a social model program about risks for self-harm. Many people come to us with suicidal thinking, as I said, often in response to pretty severe environmental challenges, homelessness, family disruption. And they can be assessed by us on one day and managing those thoughts. And then in another day, those thoughts can intensify. And we may have to look at accessing a higher level of care for them. And we have had some people who have had those experiences get seen and come back to us and stay and complete the program. With the population with as mixed a presentation and a real mix in length of stay, one of the challenges for us is meeting individual needs. We are very lucky in our staff, in the sense that both our clinicians and our case managers have a lot of dedication, and when they are working with people, they are always there to try and find the best outcome. And I think at any mental health program, you're only as good as your staff. And we are very blessed in the people that we have within our programs. When we looked at the first 160 clients served, we found 60% were referred for further treatment. And when I say referred for further treatment, I don't mean we handed them a brochure and said, here's a program you might be interested in. It's we have helped them apply to a program, the program has accepted them, and either we transport them to the program or the program comes and picks them up. So there's no gap. If we release a person because they can get into a program in 3 days, those 3 days are often days where trouble reappears. So looking at really what I would call a strong referral plan. Some people do have home and family to return to. We work closely with the managed care coordinators, treatment guardians, family members in working on the next step after crisis stabilization. I think, yeah, so if anybody has questions or you may want to wait till the end, that works well too.
Great, thank you, Dr. Harris. Very good information. Please join me in welcoming our final presenter, Pam Acosta, who is a Special Projects Coordinator and oversees the Bernalillo County Resource Reentry Center, which is the first stop for individuals released from the Metropolitan Detention Center, or MDC. Ms. Acosta is here today to speak about the RRC's goal to support individuals as they transition back into the community and to reduce the rate of recidivism for individuals who have experienced incarceration. Welcome, Pam. Thank you.
Thank you, Tammy. Good afternoon, everybody. As Tammy mentioned, my name is Pam Acosta. I'm the Special Projects Coordinator. I'm very proud to present on the Resource Reentry Center today. Tammy, you want to go on to the next slide? Today, I'm hoping to cover a brief introduction into what the Resource Reentry Center services offer, our mental health crisis response, get into our criminogenic risk, staff diagram, pre and post release information when somebody's booked into the jail, and services offered at the RRC, and the crisis services that we offer and our follow-up. Next slide, please. All right, as Tammy mentioned, we are the first stop for those who are releasing from the Metropolitan Detention Center. We are called the Resource Reentry Center, but you will see that we refer to it as the RRC often. We are located in the heart of downtown in the public safety building. We do operate 24/7 every day. And we are a voluntary program designed to be a safe landing spot for those that are releasing. We play an important role in jail diversion and reentry efforts. The primary goal, or one of the primary goals of the RRC, is assessing and connecting individuals to appropriate services in the community as a warm handoff. And you've heard Sergeant Crook and Dr. Harris mention as well that warm handoff. It's a critical piece to what we do. RRC is funded through the Behavioral Health Initiative via the 1/8% gross receipts tax. Our operational budget is $1 million each year, and we officially opened in June of 2018. Next slide, please. Okay. As we know, reentry and transition planning begins at booking. So when someone is booked into MDC, each individual completes an intake receiving screening. It's provided by MDC's medical contractor, Centurion. This screening assesses for criminogenic risk, the prevalence of substance or alcohol use, behavioral health needs, and suicidality. We recently added another piece to address opioid use. Based on the weight of the responses, an automatic score is generated, which places the individual in a particular needs group, which I'll get into. This grouping assists service providers in MDC and at the RRC to determine a level of care and connect the individual in a more focused way. So whether they complete a needs assessment, whether they do a transition plan, or whether they do something informal. Next slide, please. All right. We utilize the criminogenic risk and behavioral health needs framework. This was generated through SAMHSA and the Council of State Governments. And as you can see, it follows a tree. Each category under criminogenic risk, substance abuse, mental health has a series of questions, and depending on the answer, and it's all self-report by the client, it'll follow the tree and the bracket. So if somebody has been booked maybe more than 5 times in jail, they're under a certain age, it may place them into a medium to high criminogenic risk. Depending on their answers for substance abuse, they will follow the tree. There's a lot of substance abuse. We look at mental health next. And then at the bottom, what it does is it generates the score between 1 and 8. Now, we feel that the clients that score between 6 and 8 are most critical. They have the moderate to high needs. And so for that reason, we assign those clients to a specific group through our contractors, the UNM Hospital Transition Planning Team. Next slide, Tammy. Okay. This is a staff diagram to explain to you the different participants and where they land. So in the jail, those who scored a 1 through 5 are assigned to 12. Actually, there's 13 social service coordinators within the jail. The social service coordinators provide informal transition planning. Those are with the folks that usually have maybe a first-time DWI, who have a good support system, who can get back on their feet. They help them navigate through the jail and get connected to services while they're incarcerated. They also act as a legal liaison, connecting them with their attorneys. And then, as I mentioned, we have the UNM Hospital Transition Planners. They're currently a team of 8, and they have 6 transition planners, a case manager, assistant, and a supervisor. Their focus is those 6 through 8s that I mentioned, which are moderate to high risk. They provide formal discharge planning or transition planning. They conduct a reentry needs assessment, which covers domains that address social determinants, such as housing, food insecurities, medical needs, substance abuse, and behavioral health needs. And then we also have 2 discharge planners through the medical provider at MDC, the Centurion, and they serve all the clients regardless of score who are housed in their psychiatric acute unit. Okay. And then here at the RRC, you'll see next, once they release when they release out of the jail, we have 7 case managers here at the RRC that will meet with clients regardless of score to provide that transition and warm handoff into the community. And then you'll see into the community, we have various partners that we connect with and refer to quite often, but it's not just limited to our contracted partners, it's anyone in the community that works with the criminal justice involved or behavioral health involved. Next slide, please. Okay. Prior to release, as I mentioned, the transition planners will meet with the groups who will score a 6 through 8 and that are considered moderate to high, and they complete a reentry needs assessment and a transition plan. The transition plans have goals and action steps that assist the client in guiding them to successful outcomes upon release, whether that be getting connected, to a provider that can assist them in getting a identification, getting their methadone, Suboxone, etc. Efforts are made prior to release to connect clients with services and long-term assistance. So we make efforts to schedule appointments before they get out, whether that be with a doctor or making sure that they have a mental health provider when they get into the community, making sure that they have applied for Medicaid before they get out. And then we also, these teams that you just saw on the staff diagram, we meet weekly to discuss cases and just to make sure that the communication between all of our groups is, that we're all same paged. Okay, next slide, please. Post-release. So upon release, MDC transports clients directly to the Resource Reentry Center. Like I mentioned, it is a voluntary program. However, clients do have to walk through our center. Our colors are vibrant, you'll see in the slides following, and we offer them snacks. We greet them. It's a very warm and friendly environment. They have an opportunity while they're there to meet with a case manager who will assist them in materializing the plan that they developed while they were in jail. That's not to say that those who haven't completed a transition plan cannot meet with a case manager. Those who may be a rapid releaser who were booked in and released in less than 24 hours, they also have an opportunity to meet with a Resource Reentry Center case manager to conduct a reentry needs assessment and a transition plan, or if they just want to ask questions about resources. We do follow-up phone calls that for anybody who's completed a resource reentry or a reentry needs assessment, anywhere from 30 days to 1 year post-release. We want to find out about their status. Did they connect with the service that we linked them with? If they didn't, how can we get them connected? Or do they have any other questions or have any additional needs that we can assist them with? Okay, next slide. All right, so as you can see, this is an image of our computer lab that we have here. We offer free Wi-Fi and free internet service to clients, and they can use our computers. These are that's just one glance of the services that we offer. But while they're at the RRC, individuals can make phone calls, they can charge their cell phones, they can use a computer. Again, we offer snacks, coffee. They can wait for a ride, and we also offer the opportunity for somebody who needs to spend the night. If they're released in the middle of the night, they can wait until morning. They can stay here. We have some cots. RRC staff are available to connect individuals with resources such as Medicaid and SNAP, transportation, clothing, shelter, case management, medications. A lot of clients are releasing from MDC with prescriptions, and we help them to make sure that they know how to access those prescriptions. We have a partnership with the Veterans Administration. We have a Veterans Justice Liaison. We provide COVID education. We also supply Narcan and provide the education for that. And we connect them with jobs and education if they want it. It's all referral based. All right. Here's a few highlights and some more photos of the RRC. As you can see, there's a television on your top right, and right beneath that is our charging station. It's one of our most used features or amenities there at the RRC. And below that, we have a photo of our kitchen, and there's sandwiches, coffee, and we have a bunch of brochures. Usually folks will start to look at the brochures, and then they'll want to meet with a case manager. Again, we treat it as if it's a store in a way, where we allow folks to browse, get acclimated to our environment, have a sandwich, and then we approach them and we use motivational interviewing to engage them. So a couple highlights. We have an active greeter process. When the van arrives, we introduce them to the RRC, let them know where they're located. Sometimes driving in the van, they get disoriented. There's no windows, and so we just remind them of their sense of direction. We have a notification system set up with the jail. The jail's been a really critical partner with us, and they'll notify us 30 minutes before the van is about to leave. And this gives us the opportunity to research all of the clients that are on the transport van to see if they've completed a transition plan, to see if they have any needs that we need to address, or if they may be working with a treatment guardian that we need to contact so that the treatment guardian can meet them there at the RRC. As I mentioned, we do use motivational interviewing. And so that can start simply just, if they're sitting at the lounge, hey, what are your next steps? And before you know it, we have them in our office and we're conducting an actual formal plan. We are using currently, which is a hot topic, throughout the nation, a universal release of information. And this universal release of information allows us to have several partners listed at once on one sheet of paper. The unique part about this universal release of information is not only does it allow behavioral health to speak to these entities, but it allows these entities to speak to one another as well. We do use the VI SPDAT for housing, and we offer motel vouchers and bus passes as well for those that qualify. We have a clothing donation center. It's donated by the public. And so we recognize that sometimes somebody may be booked in during winter and they're released in summer, or vice versa. They are booked in summer and released in winter. We want to make sure that they have the proper clothing and that they're not cold when they get out. We do the follow-up calls, as I mentioned, and we also have an RRC business card. So for folks who just want to come in and leave right away, we'll hand them our business card. And if they realize maybe a couple days later that they have some questions, they can call us back. We have a good partnership with Metro and District Court pretrial services, where we help to make sure that folks that are releasing that have to report to these entities get where they need to go. They're co-located in our building, and we'll escort them up to make sure that they're in compliance with their conditions of release. Again, as I mentioned, we have our warm handoff, and we have satellite offices. And outside of COVID, folks can, agencies can come in and meet with their client. It's a safe environment. And we do offer transportation in addition to the bus passes. We recently started this where we will transport a client directly to an agency. So if they have to report to, say, our care campus or to a substance abuse program, we can transport them directly there. Next slide, please. Okay. So crisis services and follow-up, we recognize that those who are releasing from jail may be releasing to unknown or unresolved situations, and they may be experiencing some uncertainty. So we'll connect them with our 24-hour crisis to the 24-hour crisis and access line through NMCAL, or as to the peer-to-peer warm line. It's something that we've had a few people take advantage of. We have them sit down, you know, they may have left a situation where they were using drugs when they got arrested. They're anxious about, and they've sobered up while they're in jail, and how do they get back into that home and restore some relationships that may have been broken before they were arrested. And again, we attempt to follow up with 30 days to 6 months to inquire on their status, connect clients to resources, and offer information if needed. Next slide. That's it for me. I appreciate your time. And as Marcia mentioned, or Dr. Harris mentioned, if there's some questions, I'm happy to answer any questions. Thank you for your time.
Great, thank you, Pam. That was very helpful. We would like to provide some time for viewers to ask questions via the chat box or YouTube live stream. Are there any questions?
At this time, there are not.
Okay. So we have a question that we'd like for the panelists to maybe discuss a little bit. That question is, what impacts on behavioral health have you seen as a result of COVID-19? And what are your thoughts on the long-term effects that the pandemic will have on the landscape of behavioral health service delivery? So any of you have any thoughts about that? Can you share what your agencies are anticipating?
Tammy, I can answer a little bit about how COVID initially impacted the Resource Reentry Center. We saw early on that clients who were booked into MDC prior to COVID and were released during COVID were coming into a whole new world. So we had to spend some time, you know, educating them on what this new world was going to look like. You know, masks are required, washing your hands, stores are different, restaurants are different. And so we walked them through that. We provided a COVID 101 education flyer to them, sat down with them, explained what that meant. We did see a change at the jail, and that there were less arrests being made to avoid folks from getting incarcerated and being exposed. If you think about it, MDC is a ship on land, and so we saw less arrests of people getting in there just to avoid the COVID exposure.
And Tammy, I'll add a little bit. One of the things that I think we saw in the care campus was a really high level of interaction between city, county, and state governments around vulnerable citizens who might be coming for services, who maybe were symptomatic for COVID, had tested positive. There was a lot of coordination to develop wellness hotels and services so that those people wouldn't just be sort of left. And it was a joint effort amongst the various agencies with lots of communication and coordination with a goal to serving that very vulnerable population. On the care campus, one of the things we did have to do in terms of some of our services is reduce somewhat the number of people we could serve in order to maintain the social distancing required to keep everybody safe. Our medical unit, which is staffed by UNMH, really helped us in terms of assessing for symptoms that might be of concern, helping us in terms of getting testing if we had concerns about clients who might be ill, and just everybody coming together to maintain keeping services open, trying to keep clients safe, and also our staff. So it has taken a lot of resources, but there's been real demonstrated coordination, which was great to see.
Great. Thank you both for expanding upon that. We did have a question just come in on our chat, and it's to Sergeant Crook. The question is, how does APF, should be APD, I believe, Albuquerque Police Department inform officers who are not directly involved in CIU about the resources within CIU, such as mobile crisis teams?
Sure, yeah, we have protocols first off when the officers should be reaching out whenever there's a behavioral health related call. We have an RTC, a remote communications center that has a database with not only with individuals in behavioral health, but whenever it comes to resources, if they've used a specific resource before in the past, hopefully we have record of that so that we can continue to try to contact them and do some follow-up in that direction. My unit's also responsible for getting out, we have a lot of social type referral cards for resources that officers often carry in their vehicles and have access to, and they're full. There's a lot of resources on those cards that they can hand out to any individual at any time. Does that kind of help answer that question?
Yes, thank you so much for that, Sergeant Crook. Another question has come in for Dr. Harris. Does the county offer equine therapy for clients?
We do not currently offer that service. A part of the issue right now is in terms of going out into the community. That's one thing we have not been able to do because of COVID, take people on outings and other kinds of things. As it happens, we have a staff member who's quite interested in equine therapy and has seen some real benefits. So I won't rule it out as we go forward and develop that sense of sort of reconnecting with the community.
Thank you for that. Do you happen to know if there are resources in the community that offer equine therapy?
I do know there are resources. I unfortunately don't have a lot of specific information, but yes, within our community, we do.
Okay, thank you all so much. So I don't think that we have any other questions. Here, we have one more. Pam, do the caseworkers reach out after a client has left a RRC?
Thank you for that question. Yes, actually, like I mentioned, we do phone calls 30 days to a year post-release. Sometimes we find when we make these phone calls that either they are incarcerated or maybe they've gotten a job, but we do follow up with clients, and really we just want to find out if they connected to the resources we provided to them, and if they didn't, what was the reason, what was the barrier, how can we help them overcome that barrier, and say, for instance, and also look for if they need any additional resources. So maybe they did connect, but they have more questions. And usually we find this happens a lot once they're released. They're excited to get out, and then when reality sets in, they're like, oh wait, hold on, I should have asked about this. And we provide that information to them.
Great, thank you for that, Pam. So I will ask one more time just to see if there are any follow-up questions. And also just to mention to our guests, as well as anybody else that might be watching this stream afterward, please refer to our website that's listed here on the slide if you have questions or need more information about services and resources in the community and collaborative efforts that we have with our partners. These are all going to be available on our website, which is here on the slide. And it looks like I don't think we have any additional questions. I'll give you all an opportunity to add anything if anything came to mind that you wanted to add before we sign off.
I thought of one thing to add to. I love the idea of the equestrian therapy. Just a testament to it myself. One thing that you can look forward to with the Albuquerque Police Crisis Intervention is we got our first crisis intervention dog as well that we're going to be using. So we'll be able to use that on some follow-up calls. We're still working out the logistics of how we're going to do it, but I've seen that expansion of using animals to help in other situations. And I'm really happy to see it expand to crisis intervention as well, because I think it could be a great thing. And maybe that's something I could contact our horse-mounted unit about too.
That's a great idea. Thank you, Sergeant Crook.
Tammy, one thing I would just add about crisis stabilization, just in the last couple of weeks, we've expanded to the point that any behavioral health provider who has a client that they think would benefit from the crisis stabilization unit can now make a direct referral to our program. So just to let people know that that's a new option.
That's a great point to make. Thank you, Marcia. Okay, folks, thank you all so much for your time today. Very, very informative presentations that you've given us. We really appreciate all of your expertise and information. I think that this will conclude our crisis webinar. And if there are any questions, please reach out to the Department of Behavioral Health Services, or we can also put you into contact with Sergeant Crook as well.